I'm ready.
You ready?
Yeah.
Okay, good. Hello and welcome to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and with me, another board-certified OBGYN, Dr. Olga Valieva.
Hello.
You say that the same way every time. Very consistent.
There's only one way to say hello.
We are here today. I'm on call, and Olga is gracious enough to come in and podcast with me while we're here. And it is also Father's Day, so happy Father's Day to all of the fathers out there. And today, we're going to continue the conversation on bleeding abnormalities, and specifically, we're going to cover structural causes of abnormal uterine bleeding. And those would be uterine fibroids and a few others that we'll go over.
We touched on this when we did the abnormal bleeding as far as what the different causes are, so we're going to go a little bit more in depth today.
Yep. And some of those causes, just to refresh, would be fibroids, and that'll be a big part of our conversation today. Endometrial polyps, adenomyosis, and there are a couple more rare ones, maybe cesarean scar defects, or AV malformations, or arteriovenous malformations. And so we'll go over the background of these different things, diagnosis, and kind of a brief overview of the treatment. But there's a lot of treatment conversation to happen with things like fibroids. So I think that could be even, again, one of its own podcasts.
Definitely.
So let's start out with uterine fibroids. Something that is very common.
One of my favorite things, Eric. I'm not going to
lie. But it is one of our favorite things to take care of when we first see a patient coming in our schedule with uterine fibroids. And so I guess why would someone come on to the schedule, see us because of fibroids? It's probably because they're having symptoms. But there's a few big questions, I think, often when patients are diagnosed with fibroids is, I think the biggest question is, are they cancerous? How is this going to affect me? And we'll go into that.
I think it's important to know that fibroids are incredibly common. People think that they're pretty rare, but unbeknownst to most people, they happen in about 70 to 80% of women, and they're usually really, really small. People often ask, why do I have fibroids? Where are they from? And we don't really have a good answer. Sometimes it's genetic, but we just like to grow things. We grow little skin tags, we grow fibroids, we grow little things all over our bodies. And while they're technically considered tumors, they're not really a tumor type thing.
Yeah.
They grow from the muscle layer of the uterus, and sometimes they can be in different locations along that muscle layer. Sometimes they stick into the uterine cavity. Sometimes they're on the outside. They can be really small, which most of them are. And by that, I mean an inch or less. And sometimes they get really big. And when they tend to get big, that's when they start to cause symptoms for women.
Yeah. They just come, what we know is they come from the uterine muscle. And so it's one of the smooth muscle components, and all of a sudden it gets triggered. And so these are generally problems in the menstruating years. Generally fibroids stop growing when someone transitions over through menopause. And so we know they're kind of hormonally driven, but if 70 to 80% of women have them, well, the big question is, are they causing symptoms? And that might only be 25% of that number.
Right.
And so if we know that generally they're not cancerous, I guess, so to answer that question, are they cancerous? We generally say no.
Pretty rare. It's really rare. And the cancerous ones, well, there's no way to tell unless we do, the actual surgery and examine it with pathology. They do have a very specific appearance on imaging and on ultrasound. So for the most part, we're talking thousands. That's how rare it is. For the most part, fibroids are benign and rarely cancerous, but it is something that we do consider when we're consulting women as far as management.
Right. I generally try to reassure patients that these aren't cancerous. There is a theoretical risk, and like you said, 1 in thousands. Some studies showed maybe potentially right around that number, but one other study showed maybe 1 in 10,000. And so, yeah.
I feel like I've seen it only twice since residency. That's how rare it is.
It's one of the rarest cancers that we deal with in GYN, but definitely a scary one if it does come up.
Yeah.
So what symptoms would someone have with fibroids?
So most commonly women with symptomatic fibroids would come in with either concerns of bleeding, heavy bleeding, abnormal bleeding, or what we call bulk symptoms like pressure, pain, pressure like on their bladder, frequency with urination, or difficulty with their bowel movements because the fibroids are compressing on their colon. Those would be some of the more common ones. Sometimes we see women with infertility because of their fibroids, and this is usually when the fibroids either get so large or so numerous that they're obstructing the lining or endometrial cavity of the uterus. Sometimes we see women because they're having pain with intercourse or just pelvic pain in general, or heavy pain with their menses. And sometimes the fibroids get so big that they start to degenerate or die, and that in and of itself can cause pain. So these are some of the reasons that women come in for evaluation for their symptoms.
Yeah. Fibroids love blood.
They love blood.
And they will, when they get this trigger to grow, they will recruit more blood and more blood vessels to the uterus. And Olga and I have seen this firsthand when we were doing surgeries for fibroids, when someone has large fibroids. And when we there's no definition for large fibroids, but like for me, if a fibroid's kind of getting baseball size or larger, that's kind of like my threshold for saying this is a large fibroid. But the vasculature that goes to the uterus, the blood vessels are just so engorged.
There's so many. And they're also in random places, so looking for them is always tricky within the surgery.
Can distort the anatomy a little bit.
Yeah.
And so... when these fibroids like grow too big and they grow so fast that they kind of outgrow the blood supply, I think that's why you would see them degenerate on the inside, and that can be quite painful.
It is painful, and it often happens when women are pregnant and have fibroids because during pregnancy the focus is supplying the fetus with the blood, but then the fibroids are getting greedy and then they're not getting their own blood supply, so they get mad. They get really mad.
They can get mad.
They're not
and
happy.
A lot of the symptoms too, because patients might come in because they have symptoms, but also maybe they did an ultrasound because for another reason, and they incidentally found a 1 to 2 centimeter uterine fibroid. And I'll maybe put an image on here where I can draw to show you, where they would be located. But where they're located too might also depend on the symptoms too. Like if someone comes and sees me, they're having debilitating pain and they have a 1 centimeter fibroid just located in the middle of the muscle, I mean, that's probably not the cause of the pain. But the bleeding symptoms, they can be towards the center of the uterus where the bleeding comes from. And that, theoretically might have a higher chance of causing more bleeding symptoms versus if it's on the outside of the uterus, more in the abdominal cavity, that might not have as many bleeding symptoms. So location matters for symptoms, but also for treatment, as we'll get into right now.
Yeah. And some women, they'll ask, what do I need to worry about my fibroids? Do I need to treat them and manage them? And my answer is always, well, it really depends on your symptoms and how much they're impacting your quality of life. Again, that's where a lot of the reassurance for, no, this isn't cancer, this isn't really going to turn into cancer. But if it's bothering you and if you're getting a lot of pain, then then we should probably deal with it.
You're not going to want to watch the video for that second, because I just took out my retainer. I realized that's why I was talking like that.
I didn't even notice. Solid work. Okay.
Yeah.
All right. So in terms of treatment, so what are some of the ways that we can treat these fibroids, Eric?
Well, one question is, are they causing symptoms? Because they don't necessarily need treatment if we talked about like they're a smaller fibroid to medium-sized fibroid and not causing any symptoms. But you can, if you are having symptoms, and usually bleeding is a symptom, and we'll focus on that because we're talking about bleeding causes. So we'll focus on bleeding as a symptom. You can try and fight it hormonally. So there's a few different options. Can be something like a birth control pill, which is basically a hormonal pill where we can try and regulate the signals to these fibroids, and so they might respond to that. If you're having bleeding symptoms, another good option would be a Mirena IUD, which is a levonorgestrel IUD, or one of the hormonal IUDs. A couple other more rare medications that we use, basically GnRH agonist, antagonist, Lupron, or I don't want to say too many brand names, but Orlissa, can start to decrease that hormonal signal to the uterus by enacting where some of those hormones originate in the brain.
We don't use these for long-term management just because it can cause
Right.
bone loss and issues such as that, but we can use them sometimes. They do help shrink the fibroids a little bit because they stop all the hormonal flow to the fibroids, and fibroids need hormones. So sometimes we can use them to get us ready for surgery and shrink the fibroids to make the surgery a little bit easier, but we typically try to stick with more hormonal management. For women who are done having kids or are not interested in kids, there's another procedure. I don't know if you're planning on going into it. It's called uterine, more surgical stuff, where it's a procedure that essentially causes shrinkage of these fibroids too. Yeah. But if we can manage the bleeding hormonally, that would be probably the easiest thing to do.
Yeah. No, yeah, we're going to go into that. One other medication that, is also used that we're starting to use more in women's health is tranexamic acid. That's a non-hormonal option. If someone absolutely cannot tolerate hormones for some reason, this could be a good option to use to try and decrease some of the bleeding during the heavy bleeding cycles. And so often when we're using medical therapy, it can work, but it's not going to get rid of the fibroids. Generally not going to, so it might be a Band-Aid over the problem, but it all depends on the patient's desire for things like future childbearing. And now we'll get into the surgery options where we, one of the questions I often ask with patients too is to just get a better understanding is what is your desire for future childbearing, because that might help to steer us to a better option, more definitive option for treating the fibroids. But some of the surgeries that we can do for fibroids, again, it depends on their size. It depends on their location. And so if a fibroid, nicely enough, is located within, towards the inside of the uterus where that endometrium layer is, we call those submucosal fibroids. They are easier to get at with a procedure called hysteroscopy, which we'll go more into in our next episode. But hysteroscopy is a nice, minimally invasive day procedure, surgery, where we can shave off these fibroids with minimal disruption to the uterus, to the patient, to minimal pain, and basically an easy recovery if the fibroids are located in that specific area. But if they're not, access to those fibroids is a little more difficult. Olga mentioned another procedure called uterine artery embolization. And so this is an option. If someone has, and usually the radiologist doctors are the ones doing this procedure, so it's not us doing the uterine artery embolization, but that is a procedure where they use a small little catheter and put it in your blood vessel. And I explain to patients this is very similar to like how they would do a heart catheter for somebody that has like a heart attack or stenotic vessels, but they use a catheter, put it in the femoral vein, if I'm not mistaken.
But in the groin,
in the groin, and try to find that blood flow to the uterine artery. Sorry, the femoral artery.
Did you say vein?
Yeah, I did.
Didn't even catch you. Dang
and
it.
And it's right in the name of the procedure. That was not great. Femoral artery, to go up and try and actually find the blood flow to that specific fibroid and block it. What's your experience with uterine artery embolization?
I would say women do get a lot of relief from it. The downsides is while it does shrink the fibroids, it does help with the pain, but sometimes it doesn't always manage the bulk symptoms very well. And I think because it doesn't remove or destroy the fibroids completely, I feel like I have less women wanting to choose this option. But for those that just cannot have surgery or they're just not good candidates for surgery, I've definitely had a few patients go that route.
I would say, uterine artery embolization, I mean, for the patients that I've seen, and not many patients choose this option.
That is true.
It's marketed as a non-fertility sparing option. So what that is you wouldn't necessarily, if someone's like, hey, I want kids, can you give me a fibroid treatment? This isn't necessarily the option for you because it shouldn't be done for women that are wanting to conceive, just because it doesn't know what happens to the uterine muscle layers when this basically death of that fibroid, which can be a pretty brutal process, happens.
And if we're cutting off the blood supply to the uterus, is that uterus going to be able to sustain a life afterwards, right? And I don't think anyone's done any good studies.
And it's hard to study that when you're dealing with like pregnancy.
Absolutely.
When we talk about recommending a procedure, and it's nice because this is minimally invasive. It's not a surgery. We don't have to cut into your abdomen or anything like that for this surgery. But what's the chance that you're going to have another procedure? with a uterine artery embolization, it's kind of high. And so the chances of that, you have this procedure and then might need something like a hysterectomy down the road, could be as high as 40%.
Yeah. And this procedure only shrinks the fibroids by like 30 or 40%. It doesn't get rid of them. So you'll still ultimately have the fibroids, and they're smaller and hopefully less symptomatic. So if this is all you really need, then that's great. But often women come back to have a more definitive procedure, like Eric said.
Big symptoms can happen with this, though, because, again, that fibroid is dying or degenerating, like we talked about in the past. That can be very painful. So I've actually had patients admitted for days on IV medicines with this.
That's more rare. Usually we can manage them outpatient.
Yeah, I've seen it a few times.
Yeah.
And, yes, that would probably be the minority. But, so that is an option.
I think we're saying it's not our favorite option.
It's not our favorite option, honestly. There's another procedure that's coming out, and that's where they can actually do, procedure name Accessa, but it's the fibroid, basically ablation.
Yeah, radiofrequency ablation.
So it uses radiofrequency ablation. It's a laparoscopic surgery, and so again, data is not. You're not necessarily doing this for people that want pregnancy, but basically what you can do is a laparoscopic surgery and use this little harpoon, for lack of a better way to put it.
Prongs, Eric. Prongs.
Looks like a harpoon into the fibroid, and it can ablate the fibroid, and that can also, same goal, shrink and get rid of these fibroids. The nice thing about this procedure over the embolization is you can treat multiple fibroids better. And the process of the way that it kind of destroys the fibroid, and not like this slow over time, it kind of like destroys it instantaneously. And so I don't think that post-operative or post-procedure pain is as high as maybe the ablation or cutting off the blood supply is.
And one of the benefits of the radiofrequency ablation is we can target smaller fibroids too. Sometimes, when you have tiny little fibroids, but you have a big uterus, embolization may or may not be able to get all of them. So if we can, using ultrasound guidance, using the RFA specifically, go and target every single little fibroid, it's a little bit easier to manage those for women. So it's definitely an option.
It's a good option, a newer option. So it definitely isn't everywhere yet. Because then we're getting into the procedures where, it is a little more of a procedure. I would say, for things we're talking about myomectomy versus hysterectomy, both of us are big proponents of doing these cases minimally invasively. And so that would be laparoscopic surgery for a majority for both of these things. And these can be done with an open abdominal incision, but as minimally invasive type surgeons, we much more prefer to take it. So we'll talk about it in that sense. But when you have a patient with large fibroids, kind of how are you counseling them with myomectomy versus hysterectomy?
Well, I think, it goes back to what is their desire for childbearing. If they want to have an option for pregnancy in the future, myomectomy, which is just removal of the fibroids, is really their only option at this point. With a hysterectomy, removing the uterus, they can't themselves carry a pregnancy. And then there's some women that maybe they're not planning a pregnancy, or they don't want a future pregnancy, but they don't want to lose an organ as well. And, hysterectomy, yes, it is a big surgery, and there is slightly more risk involved with it. So in terms of recovery, it does play factor as far as how much time women are able to take off from work or for the recovery, and also what are their medical conditions, right? So, but the big one, I think, ends up being desire for fertility. If women are done having kiddos, just be done with it, because even if we can take out your fibroids now, who's to say that new ones aren't going to crop up and cause issues in the future? So that's something that definitely goes into counseling. But both are good options.
Yeah. And we'll have a nice surgery consult video for both of these options going forward. But the big question, unfortunately, we don't like to spring this on people, but is, desire for future childbearing. Because myomectomy, the idea of saving the uterus is nice, but as long as that uterine muscle is there is a chance these fibroids can come back.
Absolutely. And I would say that if women aren't sure, I don't I usually will recommend a myomectomy over hysterectomy because I don't want to be the one to say, well, you're not sure, but I'm going to take out your uterus, right? Like that's not a very friendly thing to do. So if you're unsure, you get a myomectomy. It's like Oprah, you get a fibroid surgery.
You get a fibroid.
And I think myomectomies are kind of fun surgeries. It's kind of like
it is one of those satisfying type procedures when you're able to get that fibroid out. Maybe we can put some video on there for the surgery consult video, which hopefully it's not going to be too long.
Yeah. And if anybody's wondering how we actually do this laparoscopically, so Eric and I both operate using robotic technology, but this can be done without robot as well. We make multiple small incisions in the belly, and then we shell the fibroid or fibroids off of the uterus, and then essentially use a procedure called morcellation, or cutting them into small pieces, and are able to pull them out of the small abdominal incisions contained. The alternative is to do what we call an open or abdominal myomectomy, where you make a very large incision in the belly. We try not to do that since it's not exactly minimally invasive. You're in the hospital for days, but it is an option for those that don't have access to laparoscopic procedures, or for people who don't have training for that. I think we're both kind of gluttons for punishment ourselves, but if we can put a trocar or robotic instruments in someone, we're going to try to do it laparoscopically.
Yeah, and a point for patients like to advocate for themselves. As Olga was saying, everyone, or depending on your resources as a hospital or experience, or for a point where patients can advocate for themselves. If you're ever potentially recommended myomectomy or removal of the fibroids or hysterectomy, and it's going to be planned as an open abdominal incision or a C-section like incision or larger, maybe get a second opinion. I mean, there's a lot that goes into those decisions, but and I think we talk about that more in the future, but the standard of our profession and care now should be for all surgeries to be as minimally invasive as possible. So let's move on.
Okay.
We could talk about that forever. But true. We have other topics to discuss. Okay. I like adenomyosis.
It's a fun one.
It's the lesser known, in my opinion, kind of like cause for abnormal bleeding, dysmenorrhea or painful menses. Maybe somewhat related to endometriosis in a way, but what it is the endometrial layer of the inside of the uterus invades into the uterine muscle, and that still goes through that growing and shedding process, but in the muscle where it shouldn't be, and that can be quite painful and disruptive. As far as bleeding symptoms and pain symptoms.
And it does cause enlargement of the uterus, and the larger the uterus is, the more room there is to bleed. So the uterus also can't really contract. The muscles can't contract when there is involvement of the muscle or the endometrial layer in there, and it's more or less full of blood. So it causes more pain. It causes more bleeding.
It's just a big inflamed, boggy uterus. It's an
angry uterus.
You can... adenomyosis, you can't always see it necessarily on ultrasound. Sometimes on MRI, you can pick it out a little bit better, but you can't always see it, but you can suspect it. And again, it's one of those big questions, kind of like fibroids, as far as the treatment options for adenomyosis. You can try and treat it medically, because again, it's those endometrial cells that are causing the problem, and we know they respond to hormones. So you can try and do hormones with birth control pills, IUD, but inevitably the definitive treatment is surgery and removing the uterus with a hysterectomy. However, there are some people that would potentially try and take this, cut it out like you're doing a myomectomy.
Because sometimes they do grow into like a little ball of adenomyosis.
It depends how it kind of looks. And so you can take out adenomyosis, but adenomyosis is like fibroids are much more distinct. They have this, they're like a baseball in consistency. Sometimes like they're that hard, and they're round usually, and so they're easy to remove. But sometimes when you're doing adenomyosis surgery, it's really hard sometimes to distinguish what you're taking out, or is that normal muscle. And so seeing a very qualified surgeon for this would be if you're considering that, would be imperative.
Yeah. And women often ask, like, is this a dangerous condition? Is this going to stop me from getting pregnant? Things like that. It is not. It's not a cancerous condition. It's not going to lead to anything harmful. You can still get pregnant when you have adenomyosis. All it does is just cause pain and misery, really. And when women are done with their childbearing, then that would be time to intervene. If we can't manage it hormonally, that's when we would intervene surgically.
Right. And kind of there's a couple other lesser known structural causes of bleeding, and actually cesarean scar defects, because every time we do a C-section, we're cutting into the uterine muscle, and then we repair it, and it disrupts that normal interaction of the endometrium, which is the building and shedding layer for the menstrual cycle, and the muscle layer, and so it can kind of cause that same interaction and symptoms, and so C-sections, maybe can cause problems later on in life potentially. But let's go back to a more common issue. I think we can probably run through endometrial polyps in an efficient manner.
They're so cute.
They're fun little guys. They're one of the most common causes of abnormal bleeding. It can happen both pre and postmenopausal women. The nice thing is they're rarely cancer. They're extremely rarely even pre-cancer. And so, if polyps can grow all over the body. It's just a hypertrophic, we call it, or just excessive growth of one specific area. And it forms this like finger-like projection. Or tongue-like projection. A lot of them look like a little tongue.
They do. They're super cute.
And
they just bleed. They like to bleed a lot. They're very vascular, and they just...
Yeah, and so we can see them on ultrasound. I guess if there's anybody out there, I guess there are specific conditions in which, put you at a little higher risk for those pre-cancerous polyps of the uterus, and those would be like tamoxifen using patients. So that's a breast cancer treatment drug most commonly used for that. Or people who have hereditary cancer syndromes, but
pretty rare.
Yeah, but so if someone's having bleeding, like bleeding between their cycles, heavier bleeding
with intercourse,
or
postmenopausal bleeding,
we find these, like many other things we find in gynecology. We find it with an ultrasound, Again, there's option. Once we find it, we have options. Just kind of like everything we talked about. Big question is, if we know this is an extremely rare, like cancerous risk, what it could be observed.
It could be observed, and again, depends on what symptoms are and how bothersome they are too. I don't typically. I mean, I would, if it's postmenopausal, we want to resect them because there's a slightly higher chance it could be precancerous or cancerous. So if it's somebody in their reproductive premenopausal age, we can observe them, see if they're growing. If they're causing a lot of bleeding, then we talk about either an IUD or hormonal management again. And if we fail those, or women can't use those for either health reasons or personal reasons, then we go ahead and do a procedure. Eric touched on it. We do hysteroscopy, and then we very easily remove them. The problem with polyps is then they can also come back because you still have a uterine lining, so cannot.
There can be, but there can be ways we can potentially. I like to, and this is maybe diving a little bit into the next procedure. But if I'm doing a polyp resection on somebody, you're going to do that hysteroscopically, and so you can combine that with something like IUD insertion. So these can be suppressed. Polyp growth can be a little suppressed by if you use a birth control pill or something like an IUD. And so that might be a question your provider asks you if you have a polyp and are looking at management options or prevention options. So
I think those would be some of our common causes of bleeding.
Yeah, and I think for those big topics, fibroids, this isn't going to be the last time we talk about that. So we have much more to discuss regarding all of these treatment options. But no, that's it for today's podcast. Thank you for listening, and Olga, thank you for stopping by.
You're welcome. I just can't stay away from work on my
I know,
my
a
3
Sunday,
days.
and she is here at work, everybody. Come see Dr. Valieva. She is
I'm not here.
committed to her craft. If you have any questions, please let us know in the YouTube comments. As always, content of this podcast and video are for educational purposes only. None of the content is meant for personal medical advice. Please contact your provider if you're in need for that. Have a good day, everybody.
Happy Father's Day.
Happy Father's Day.